This graphic presents the findings from the health economic component of our evaluation. This part of the evaluation involved analysis of quantitative data on service use, using data provided by the services, as well as information collected from staff and services about the resources and costs involved in delivering some of their core drug and alcohol service activities, both remotely and in person. As this first box states, service user data showed a clear rise in the number of service users per month in the pandemic period. This was the case for all 4 substance use categories, and each also saw a surge in number of monthly users around June of 2020. The second box here relates to one-to-one appointment data collected by the service provider. Our analysis of these data showed a few interesting patterns. Firstly, attendance at one-to-one appointments increased by approximately 20 percentage points as the pandemic hit. When we look more closely at data on the number of booked appointments that were actually attended, we see that the proportions of appointments being cancelled fell, as did the proportions of appointments where the service user did not attend. These quantitative data support the experiences shared by staff and service users that the move to remote delivery during the pandemic led to increased efficiencies. The next couple of boxes relate to group session attendance. Group sessions were a core part of the drug and alcohol service delivery. An important finding was that the average number of group sessions being delivered per month reduced after the start of the pandemic, from about 150 to approximately 40. Corresponding with this was a fall in the average number of people attending group sessions per month. However, those who did attend tended to do so more often. This can be seen in a rise in the monthly mean average number of group session attendances from 3.7 sessions per person to 4.4 sessions per person per month. Also, the average group size of a group session increased from a pre-lockdown monthly mean of 6.2 to a post-lockdown monthly mean of 10.2, an increase of 64%. This supports the finding from our qualitative analysis that access to online group sessions may increase their degree of accessibility for some people. Staff stated that online group sessions did tend to be better attended than they were when in person. As this next finding outlines, our health economic analysis estimated that delivering group work virtually, online, is estimated to cost about double compared to when it is delivered in person. This was due largely to the additional staff resource required to run a virtual session. 2 staff members were required rather than 1, and a typical increase in admin time, for example, post-session administrative work, increased. Despite the potential increased cost of virtual group sessions, such sessions can support larger numbers of participants, so may lead to increased efficiency in terms of service delivery. Delivering some aspects of support, such as initial comprehensive assessments or developing recovery plans, was said by recovery coordinators to take less time virtually, and virtual delivery therefore had estimated lower cost. However, staff also indicated that such virtual delivery may miss out the important rapport or relationship building that in-person provides. Also, virtually completed comprehensive assessments may represent something of a false economy, as they may not capture the depth and detail that is captured in person, which may necessitate additional follow-up work later on. Finally, qualitative data analysis showed that virtual delivery meant some savings in terms of time and out-of-pocket expenses for service users, primarily around travel expenses. However, these savings were significant for some service users and less so for others.